The thumb is distinct from other fingers anatomically as well as biomechanically. And you know that the mobility of the thumb is very important in the hand function. Accordingly, fractures of thumb metacarpal are discussed differently from other metacarpal. So coming to the incidence of first metacarpal base, first metacarpal fractures constitute about 25% of all metacarpals, and it is the second most common fracture, and the first being the fifth metacarpal. Over 80% involve the base, and out of these 20% are intraarticular. It's not commonly seen in young males. And the mechanism of injury most common is the axial loading along the axis of the thumb with an element of flexion. And the mode of injury may be a fall or a direct secondary to sports, bicycle accidents, and punching against solid objects. The muscle importance on the thumb are important considering the displacements of the fractures. Mainly the APL, abductor pollicis longus and extensor pollicis brevis, are responsible for the proximal exert a proximal dorsal and radial force on the shaft, and the adductor pollicis produces supination and adduction on the distal part or distal part of the metaphysis. Considering the ligaments, most important is the volar oblique ligament or volar oblique ligament, which is responsible for maintaining the triangular volar ulnar fragment in place in case of a Bennett fracture. The first carpometacarpal joint is a saddle joint, locking reciprocally, and it provides multiplanar movements, mainly flexion and extension and adduction and abduction. In both movements, rolling and sliding movements takes place of the base of the metacarpal takes place of the saddle surface of the trapezium. Coming to the clinical presentation, it is a fracture diagnosis similar to any other fracture, but remember, gross swelling can mask a marked angular deformity. Regarding investigations, recommended radiographs are true AP view of the trapeziometacarpal joint, that is the Roberts view type. It's an hyperpronate view of the thumb. And other view required is a true lateral view. This is the Robert view showing an exact AP of the trapeziometacarpal joint. And optional views are oblique, and CT scan or a traction X-ray may be necessary in some cases. Coming to fracture classification, this fracture is classified into 77-1-1A. The first one represents the metacarpal, and the second one represents the proximal region, and A is extra-articular, B partially articular, and C complete articular. Commonly this is classified as extra-articular fractures and intra-articular fractures, and among the intra-articular fractures you have the Bennett, Rolando, and severely comminuted fractures. Coming to the extra-articular fractures, it's often displaced with the flexion deformity produced by the action of thenar muscles, and there may be a combination of the volar part. In that situation, the fracture will be unstable. And coming to the principles of treatment of extra-articular fractures, the goal is to achieve acceptable alignment, stable reduction, strong body union, and unrestricted motion. Often be managed non-operatively up to 30 degrees of angulation because it is well tolerated because of the great mobility of the adjacent joint, whereas more than 30 degrees requires operative management. Coming to the treatment, operative management, reduction and fixation of the extra-articular fractures. Thumb function may be impaired due to the gross angulation resulting in muscular imbalance, and internal fixation allows anatomical reduction. If there is palmar combination, there is chance of delay in union. In that situation, you may have to do a bond grafting, especially if you are not using a locking compression plate, or if you are using an ordinary plate, you may have to do bond grafting also. Coming to the approach, this is approach through a radio palmar approach or a dorsal approach. There is a radio palmar straight approach or a vaginal approach can be used. And reduction is, indirect reduction is possible using a locking compression plate, or you can go for a reduction by traction. The technique of reduction is axial pull along the thumb with supination of the thumb, pronation of the thumb, and direct pressure of the base. The fracture will get reduced. A temporary cover fixation stabilization is done, and select the plate. Ideally is a 2 mm LCP T plate. The length of the plate, there should be minimum 2 screws in the distal fragment. And contouring is important. The transverse section of the plate is contoured according to the curvature of the base of the metacarpal, and longitudinally it is contoured to avoid penetrating the proximal screw into the joint. And after the first screw is fixed, align the plate with the shaft of the metacarpal, and then you go ahead with the fixation of the second, third and fourth screws. Post-operatively, it's better to immobilize in a plaster slab splint initially, which can be transferred to a thermoplastic splint later, which can be removed under supervision of a physiotherapist for mobilization. And very rarely this is used tension band wiring, not very common tension band wiring for interarticular fractures. Coming to interarticular fractures, Bennett, there is a single major fragment held anteriorly and volar and ulnar part with the attachment of the anterior oblique ligament. The rest of the metacarpal will be displaced proximally and dorsally due to the pull of abductor pollicis longus and extensor pollicis brevis. So there are 3 types of fractures have been identified. Type 1 is a single volar ulnar fragment. Type 2 is an impacted fracture fragment without much subluxation of the metacarpal. And type 3 is a small ulnar avulsion fracture. Treatment goals of Bennett fracture is number 1, to reposition the first metacarpal in the carpometacarpal joint and to restore the articular surface. Most authors now suggest surgical treatment, reserving non-operative treatment for non-displaced Bennett fractures. It is recommended to achieve reduction within less than 1 mm displacement. And treatment options are non-operative, very rarely used, mainly for undisplaced fractures, and the main treatment modality is surgical. Close reduction and caviar fixation, either percutaneous or open, and open reduction and lax screw fixation. Coming to the non-operative management, the close reduction is done and cast is applied. It is very important to maintain the reduction during the application of the cast. If you apply this, the force should be applied on the base and the opposite direction on the head of metatarsal, so that the first MCP will be in slight flexion, whereas if you apply pressure on the base of the proximal phalanx, the reduction will be lost. And a clasped application should allow mobilization of all metacarpal phalangeal joints of all fingers except thumb, and in case of thumb, IP joint mobility should not be restricted. Coming to close reduction and internal fixation, it is the treatment of choice for most of the Bennett fractures. Caviar fixation, 1.6 caviar is ideal, and options, there are different options. Transfixion of the base of the first metacarpal to the trapezium. Second is transfixion of the thumb base to the second metacarpal, or a combination of both can be used. And it is better to introduce the caviar after opening the base of the dorsal aspect. 1 cm skin incision can be made. so that you can prevent inadvertent injury to the dorsal branch of the superficial branches of superficial branch of radial nerve. Different fixation options are available: Wiggins, Wagner, Iselin, etc. And this method utilizes two cavers from first to second, connected externally over. Externally, connector is used, and this provides better stability. The others argue like that. And coming to open reduction, lag screw fixation. Indication: it is the most displaced Bennett fractures with a large medial fragment. In case of a small medial fragment, close reduction caver fixation is ideal. If the fragment is large, go for open reduction lag screw fixation. And treatment options, there are two options. Depending upon the size of the fragment, if the fragment is small, ulnar fragment is small, one screw and one caver can be used. In that situation, 1.2 to 1.4 mm caver and 2 mm or 1.5 mm screw can be used. The compression fixation is to be given across the fracture. If the fragment is large, two screws can be used. 2 mm screws. The position should be in the equilibrium. You have to identify where the screw enters. This can be achieved by first opening the fracture site and retrograde drilling the glide hole, 2 mm glide hole on the shaft fragment, and then reduction, and then the threaded hole can be drilled and compression fixation with 2 screws. There are reports of fixing the Bennett's fracture, screw fixation from ulnar to radial direction also, but rarely used. They conclude that the volar approach, this is through a volar approach. Volar approach offers an excellent fracture exposure, possible to place the osteosynthesis from ulnar to radial version, but technically it is difficult from fixing from a small fragment to a large fragment, and the exposure is also little. The dorsal exposure is better, easy. So this is not much popular. And next is arthroscopic management of Bennett fracture. The proponents say that the thumb carpometacarpal arthroscopy for Bennett fracture is the best method of assessing reduction while allowing for percutaneous fixation, as fluoroscopy alone may underestimate residual joint incongruity, which will lead to late degenerative arthritis of the trapeziometacarpal joint. Placement of the thumb in arthroscopic tower with 5 to 10 pound of traction aids in reduction and distracts the joint to allow for inspection of the articular surface with a 1.9 or 2.7 mm 30-degree angle scope. The position of the surgeon, assistant and the percutaneous fixation is shown. A newer method includes screw and suspension fixation, a combination of 1.7 mm headless cantilever screw plus a suspensory augmentation using a tight rope. Even though the others claim excellent early clinical radiographic and patient reported outcome, but it doesn't seem to be cost effective. Coming to other modalities, for Bennett fracture, tension band wiring rarely used but not popular, either through a small incision using a loop and headlight or completely open method. And comparing to close reduction in the ORIF, this study 2023 is the first meta-analysis comparing close reduction to ORIF, and the results showed higher grip and pinch strength, better extension and flexion of the CMC joint, and a small mean adduction deformity of the thumb in ORIF group. No significant differences were seen in the remaining outcomes. Coming to the Rolando fracture, it's a T or Y-shaped fracture. But today, the term Rolando fracture is often misused to describe multifragmentary intra-articular fractures of the thumb and knuckle. That is what the reference says. And the mechanism of injury I have already defined. The deforming forces are the same as that of a Bennett fracture. Treatment of Rolando, open anatomical reduction and internal fixation is the treatment of choice. Approach is different whether two types of fractures can happen, YOT in the frontal plane or YOT in the sagittal plane. So depending on that, you have to choose the incision. In case of the frontal plane fracture, straight dorsal approach, and in case of the sagittal plane, radiopalmar approach is recommended. Initially reduce the articular segment, then temporary stabilization with the K-wire is done, and then reduce the shaft fragment, followed by fixation, temporary fixation of the shaft fragment to the articular fragment with the K-wire, confirmed reduction, articular congruity and anatomic reduction. A limited capsulotomy will permit visual inspection, and plate preparation 2 mm LCP, as we have already mentioned in our same. Plate length 2 screws distal should be there. Fixation is similar to the previously described technique. And coming to severely comminuted fractures of the base of the first metacarpal, that if the fragments are numerous and small, it is not advisable to attempt internal fixation. In that situation, distraction followed by an external fixation is better, and bone grafting may be necessary in case of any void after distraction. Bone graft can be taken from the lower end of radius itself. And after that, it is replaced with an external fixation. If larger fragments are there, you can add an additional K-wire also. That is after fixation. And coming to conclude, the thumb metacarpal base fractures typically occur after vertical compression or impact to the thumb. The treatment should focus on restoring the structure and biomechanics of the TMC joint, with surgery being recommended for optional results. Conservative treatment outcomes have been found to be unsatisfactory when the fracture is displaced. Therefore, surgical methods such as minimally invasive surgery, open reduction, and arthroscopic surgery have been proven to be effective. Fixation options include pin fixation, lax screw fixation, mini plate fixation, and prognosis depends on the ability to restore joint mobility during rehabilitation. Thank you so much.